Thank you for joining us for today's webinar titled How to Maximize Your Oncology Practice Value featuring Utah Cancer Specialists. First, I would like to introduce myself. My name is Clarissa Blattner, and I am the Senior Director for MDX Support Services at XIFIN, and I will be your moderator as well as a contributing speaker for today's webinar. I am joined by Patrick Shields, Director of Business Services at Utah Cancer Specialists, and David Bird, the Vice President of Growth and Strategy with Infinx Healthcare. In today's one-hour complimentary webinar, we will discuss the recent research that was performed confirming community oncology challenges, recent state legislation in the news regarding changes in prior authorization requirements, revenue cycle management challenges and solutions. Patrick will actually share firsthand experience on what the driving factors are and what he has done at Utah Cancer Specialists to implement changes, the billing and coding mindset shift, using front-end automation and technology integration solutions within the billing process, as well as the client and patient portal for direct physician and patient engagement to remove obstacles in obtaining accurate billing information and provide ease and convenience for payment processing. Dave will actually take us through a deep dive into the prior authorization process and automation possibilities using augmented intelligence. We'll also talk about closing the end-to-end revenue cycle management loop using automated workflows, patient engagement solutions, and tying everything together into financial reporting through business intelligence, advanced analytics, and AI. And lastly, we'll wrap up our discussion with a few minutes for Q&A. Community oncology practices continue to undergo a significant market shift due to a proliferation of acquisitions and mergers, payer fee schedule changes, heightened competition with health systems and hospitals, regional staffing shortages, the recent disruption of care due to COVID-19, which is affecting all healthcare settings, and many other challenges. Together, these challenges result in a need to strengthen practice financials. EBITDA, earnings before interest, taxes, interest, depreciation, and amortization, demonstrates the operating profitability of practice. The fundamental means to achieve better EBITDA is to maximize revenue and control operating costs. For most practices, the most effective way to maximize revenue is to improve reimbursement rates, and controlling cost is highly dependent on improving operational efficiencies. A 2021 study was conducted by the Links Group to understand the challenges faced by community oncology practices in revenue cycle management. Community-based oncology administrators nationwide responsible for the revenue cycle management operations cited that navigating payer requirements is the foremost challenge for community oncology practices. The top two challenges included claims denials and subsequent appeals, which were cited by 77% of respondents, followed by prior authorization requirements and processing. Patient eligibility issues, which is part of the front-end billing process, also affects everything downstream, which came in third. I thought I would actually share some recent legislation passed that's in the news today as it pertains to prior authorizations. Texas recently adopted a new law that features gold carding providers. Under the new law, if a clinician orders a medical service at least 5 times in a 6-month period, and at least 90% of the orders pass prior authorization requirements, then the clinician is exempt from undergoing prior authorization for that particular medical service for the next 6 months. Gold carding only applies to payers that fall under the state's jurisdiction and are not state funded. The law actually became effective September 2021. Physicians in Texas commented that this was a win for both the clinicians and patients alike, as it will reduce the time it takes to request and follow up on prior authorizations, as well as expedite the need for patient care. On October 6, 2021, California Senate Bill 535 was approved. The bill would prohibit health insurance and health plans from requiring prior authorization for biomarker testing for an insured with advanced or metastatic stage 3 or stage 4 cancer, as well as biomarker testing for cancer progression or recurrence in these individuals. Interesting facts, only about 50% of patients in the US diagnosed with cancer who are eligible for molecular testing actually receive the test. Also, 31% of California's insured population have benefit coverage that requires prior authorization for biomarker testing. With this recent change in legislation, 100% have this benefit coverage without the need for prior authorization. So as you can see, efforts to reform prior authorization are playing out in Congress, government agencies, and state legislature. So I know I'll continue to keep abreast of these changes as well. So we're excited to have Patrick Shields join us today to talk about the day-to-day operational challenges he's faced at Utah Cancer Specialist, as well as how he's assessed the issues, implemented solutions, and share valuable data-driven metrics showing improved outcomes. Patrick, the floor is all yours.
Thanks, Clarissa. Morning and afternoon, everybody. Pat Shields here. Technical name, Patrick Shields, but it's usually when I get in trouble. But happy to be here, talk to everybody within the community oncology space. We all know the pressures that we're facing. A lot of what I'll say in terms of, I guess I would say, hardships to our practice is not anything that you guys are probably not experiencing yourselves. So quick snapshot of who we are. We are a physician-owned community oncology practice, currently with 11 locations, with the 12th and 13th to open this year. We're also expanding our radiation oncology program to, we have a comprehensive cancer center where we provide radiation as well as our chemotherapy medical oncology. And we are expanding into 3 other hospital systems this year to provide the radiation oncologist and essentially manage these facilities' radiation programs. So pretty exciting expansion plans coming. Right now we essentially have about 40 medical oncologists, 3 radiation oncologists, and excuse me, not 40, 20 physicians, medical oncologists, 3 radiation oncologists, and the rest of our practitioners make up our advanced practitioners. We have about 23 front-end financial advocates managing the front end of the revenue cycle process, and then we have about 13 back-end denial management claim specialists. And we happen to be one of the largest treatment facilities within the Intermountain area. Gotten some interesting information from contacts within some of our payers here, and they have leaked information nicely that we are about 50% of their claim volume. So pretty big foothold here. So some of the primary RCM challenges that we've been facing here is probably not anything that you guys haven't seen today. Payer challenges in the oncology world are difficult. You know, as a lot of us are buy and bill practices with our drug fee schedules, you know, we're not just susceptible to a one-time a year change in fee schedule. We get 4 of them a year. And the difficult part about that is, you know, some of the payers are scrambling to keep up just as we are. Changes within NCCN guidelines and just anywhere else, you know, new FDA indications make it difficult for them to keep up with what they're going to essentially allow, especially on the new drug. And so, you know, it's difficult because one of the things that they do is, you know, require us a lot of the times to go out and find the information ourselves. And, you know, that can be a very difficult thing for us to do, is we have no idea if they've made changes. So it's on us to essentially every quarter, you know, follow with the payers, do their job instead of, you know, them notifying us of any changes. So we found that's been one of the difficult barriers of just keeping up with the changes, as most of us would experience. Yeah, and the lack of notification is a difficult factor. You know, I've gone the rounds with a lot of our payers to say, you know, you're the ones making the changes. I think that, you know, due process should be that you guys need to notify us of any changes, not have us go out and look for them. And so, you know, keeping up with any payer changes is always a hardship. One of the things that we've noticed recently is just that our patient balances have been essentially climbing due to COVID. I think this is probably an experience that a lot of practices have experienced, but especially with the oncology space, we have a lot higher dollar volume. And, you know, patients not just getting a typical E&M visit or follow-up or a lab, and, you know, if they get a very expensive treatment, I mean, this is a balance that they could be paying off for the next 4 or 5 years. Deductibles being at an all-time high doesn't help us, and, you know, some of these payers are coming out with the copay accumulator programs that we all know is driving costs back to the patient instead of being applied to the deductible and bringing costs down for the patient. So, you know, the hardship within a community oncology space when it comes to these patient balances is also, you know, we have very compassionate physicians. You know, I may be the stickler that might contact one of our patients and say, hey, I need you to pay an X percentage of your balance because it's growing. And, they'll get into the patients in the clinic they'll get into the clinics in front of the physicians and say, all I can pay is $10 a month for the next 15 years. And our physicians will say, all right, we'll go ahead and we'll take that. So difficult to bring down patient balances for us. Although, as an empathetic community oncology practice, I can't argue with them too much on that. COVID's been a disruption as it has for everybody. I mean, I'm not saying anything new there. The disruption for us in the revenue cycle world has been on the front end portion at time of service, and even at pre-services, we typically will notify patients with cost estimates of what they might owe. And what's been difficult is patients being furloughed, and being laid off because of COVID, downsizing. And, there was a lot of concern with, actually touching and passing information back and forth, even in, money, credit cards, and just things like that my staff got very nervous with. So my front end collections essentially came down. Thus, my patient IR has been essentially increasing ever since COVID. So that's been one of our initiatives to essentially address through 2021. Prior authorization requirements, I'm not telling anybody in the oncology space anything they don't know with prior authorization. I mean, 90%, at least 90% of what we do needs prior authorization, imaging, drug, genetic testing, whatever it may be. We have to authorize nearly everything. And we have, a large portion of what my financial advocate staff is authorizing. In any given week, they could be spending upwards of 50% of their time just driving orders and prior authorizations. The problem with that, as we all know, and as Clarissa had mentioned, is with Texas and California, some of the legislation coming out is that, payers are not using the prior authorization process for what it was meant to be. It was meant to verify medical necessity. But we all know that a lot of these payers are using it for cost control, and they're not validating medical necessity. They're using it to manage and bring down cost. And that's killing productivity on our end. I have payers where, they've introduced a benefit manager, which a lot of you have experienced with that, I used to spend 5 to 10 minutes to an authorization. Now it's increased my time to 35 to 40 minutes, depending on how much information they need. And we're all at the mercy of the payer's workflow. What do they want in that authorization? What do they need? And if, some of you might be included in some pathway programs, and if we miss a few data points here and there, we miss some staging, we miss tumor markers, we miss whatever's required, it knocks us off pathway and we lose that benefit. So a lot of difficult challenges facing us this year, and, has been ongoing for a while. So solutions that we've implemented, and some of these are honestly, not too exciting, of course, but unfortunately they have to be there, is on the payer side. We have extensive internal training. We're pretty much at the very least quarterly doing training on anything new drugs, new policy, anything that essentially has come out that might change or affect back-end rejections and denials. Anything on the front end, with our financial teams is, what should they expect in policy changes? In the beginning of the year, we all know that, policies can change. Patients' coverage can change to a new payer. Maybe their employer changed to a new plan. So the first half of the first quarter of the year, we're spending revalidating eligibility. And so, it's a lot of extensive training to keep everybody on par with everything that changes throughout the industry. So what we've done with part of that is we implement quarterly policy reviews. 2 of our teams are required every quarter to essentially assign payers to each of their individual representatives and say, look, your job is to essentially go out, see what any changes have been there, and present it to the team. And so that helps them not only learn and know the new changes, it gets us all up to speed on anything new for prior authorization, but also on the back end of any kind of new coding changes, policy changes on the billing back end side for appeals and denials. So, our reps, we highly encourage them to build rapport with our payer representatives. Some of the payers that you'll deal with, some of them are going to be difficult, some of them might be great. We find that problems and issues are quickly resolved with the better relationship we have with that payer. A few of my large commercial payers we have a great rapport with, and even if it's just before COVID, this is a lot easier, but we would do a monthly call and even a quarterly lunch with some of these guys, and just it's building that relationship. The better relationship you have, the more they're going to be able to jump and help you with any issues that you might have. Seems simple, but to me, I've always gone with the mantra that business is relationships. The better relationships you have, the easier things are going to be, and the better things can move forward, and then you can actually not have the resistance of not getting responses, because some of our payers that we don't have that great a relationship with, and we've been working on for a long time. If they're non-responsive or they're just difficult, I mean, it takes us a long time to get anything dealt with in any kind of large level issue. We've got issues with our local regions. I'll tell you that it's taken months to get through, and we finally have made a breakthrough within the last month and actually getting some issues dealt with on our labs. But it's taken a long time. We just had the wrong people, and the relationship hasn't been as good. So something that we're moving forward with. I require some time within my contract negotiation, will within our amendment section of our contracts, I'll also require providers to notify us of changes. They have to be certified notification, because a lot of the times now they're saying, we'll go to our website and look, we'll send an email, something may not get through. I had a contract that was set to expire end of last year, and I had to do all the contract language and check and everything within 2 weeks of the end of last year. And the issue with that is because our representative said, I sent it to you back in June, and I said I didn't get anything, and he had fat fingered one digit within my email address. And so we're scrambling at the end of the year to get a contract done so that the line of business doesn't drop. And so what do I do in the notification portion within the amendment now is I tell a lot of these payers that, I need to be, you are required to notify me by certified mail. I want an actual written notification. I don't want it to get lost in email in space. And then, obviously I don't want to have to rely on you going out to your website to see if you've changed anything. So something to consider within your contract negotiation. Revenue integrity is big. That's probably your biggest. You'd be surprised, in my time before Utah Cancer Specialist, I spent in practice management consulting for a third-party revenue cycle company. And one of the things that we would always come into, and even when I came to Utah Cancer Specialist, is where a lot of practices struggle is the revenue integrity. You need to make sure that you're getting paid what your contract says you should be getting paid. And that is a big one. You can't rely on these insurance companies to do everything perfectly the first time around. They're going to make mistakes just like all of us. Especially in the oncology space. We have drug schedules changing every quarter. ASPs are changing. We need to make sure that they're paying properly and that we're not leaving money on the table with any of those drugs, because this isn't just an E&M where we're losing time. We're losing an upfront cost of us paying for that drug. So revenue integrity has been a large initiative of ours in the last few years. There's a lot of companies out there that can help you manage that if you don't have a way to do that within your PM system, or if you're doing it manually. A lot of variance reporting can be done to help ease that pain. We transitioned to a company the end of 2020, and it takes some time to verify your data, load all the contracts and everything, but it's been well worth it. We've saved probably in this first year roughly about $30,000 in underpayments. So revenue integrity is a huge initiative of ours, and I think it's definitely something that should be on the forefront of everybody's annual goals. Technology, leveraging automation when we can has been another initiative of ours. Correct coding and then automation of our charge master. It's just making sure that everything is coming from our clinics and through our charge master representatives in automating what we can so that we're not touching every single issue has been something that's really been big for us. I had a department of about 5 or 6 charge master representatives just verifying charges coming from clinics. And our initiative was to maximize technology. So we automated everywhere we could. And, anything that my team was touching manually, that they'd had a process in place or a workflow in place for who knows how long, 10 years. We looked at everything and said, why are we touching everything when we don't need to? A lot of PM systems will be able to automate and push things through that you don't have to have an individual person touch and send it out the door as fast as you can. Additional integrations, anything that you can do with an outside vendor if you need, and your PM doesn't have the capability. Get outside vendors to help you quantify your data. Get them out there to tell you how well you're doing on your denials. What are you doing on your front end? Initial out the door claims percentage. With the denials as high as they are, as Clarissa showed in the first slide, is we need all the help we can to localize where the issues are. What are we doing? And how can we better essentially avoid these denials on the back end and avoid all the labor that's going into that? We're currently piloting, a predictive analytics tool for denials, and it basically takes your past claims data, does a lot of machine learning to quantify, okay, where are your issues coming in? And based off past claims, this is what we expect might happen on your initial out the door claim. And you can clean that up and reduce your claims denials from, on average, industry average is anywhere from 5 to 10%, maybe down below 5%. Anyway, so with a lot of our automation and what we've done to monitor our front end claims before they're going out the door, we increased our initial out the door clean claim rate from 75% to 97%. And I also reduced our charge master department from 5 to 2 employees. So it was a significant change for us. So patient AR, one of our initiatives again this year has been manage the growing patient AR from, the changes from COVID, furloughs, and patients just unable to pay. We're trying to be as empathetic and, as mindful as we can of hardships within COVID and everything that we've been experiencing through the pandemic. And some of it's just going to be training, and it's just going to be more communication with our patients. One of the things that we've had to do is retrain my front desk and, our financial advocates on the front end to just say, hey, we've noticed that you've got a past due balance. Did you want to take care of some of that today? How do you feel about making a payment? And we let the patients drive the conversation. We need to remove any kind of barriers for our payments. We didn't have a robust back end portal that would allow patients to go online and make payments through their mobile or just anytime they want, and through, on their phone, basically through an IVR system. So one of the things that I've known through the HFMA is that one of the first things that happened to a lot of hospital systems and physician groups was, as soon as they were to the point of sending the AR teams home and all of the revenue cycle teams, the first thing they did was implement an IVR system to allow patients to call in, make payments 24/7, anytime when you're out of the office, closed on the weekends. A patient could call in and also just make a payment at any time through the IVR system. Doesn't remove that individual. We don't ever want to remove that individual. Obviously, this is too complex a healthcare system for us to go completely automated. We need to find that hybrid between a human being and technology. So IVR is a big thing. One of the things that we've also implemented on the back end that we did not have, at least, but not a very robust system, was a patient portal that allowed them to make payments, allowed them to set up recurring payment plans, sign up for SMS text notification, e-statements, keep cards on file, remove those barriers, allow patients to get to their bills when they need to, allow them to see what they need to pay for. And one of the first things that happened to us as soon as we initiated that is patients just called on every new statement that we'd send out, on every new process. And, the first month, sometimes there are those growing pains. But some of the results of us, and changing to this new portal and a very robust functional portal was that, I had more functionality. I could create payment plans and give the patients options. They had the option to talk to my people and say that, I need a little bit more flexibility so that my team can decide if they need more flexibility or not. Some of the results we had from this new patient portal system was, you can see there, we increased our self-service payments and by 88%. And these are the patients that essentially just went to the payment portal, found their accounts, did what they needed to do, and paid their balances. And 60% of all online transactions these days are done by mobile. And our last portal wasn't able to function on a mobile platform. So I think this has greatly increased our patient interaction. We decreased our incoming calls to our AR team by 35%. and that's more time that they can spend on, unfortunately, dealing with those denials and dealing with those appeals that they have to deal with. Automatic payment plans increased by 134%. This was big for us. This is just a reoccurring automatic payment plan that we don't have to chase people down. We don't have to go find them and say, you missed a payment. This is going to be something that automatically happens and then notifies them if if a card, say, has non-sufficient funds, or maybe they've changed a card and, they didn't tell us about it, it'll notify them as well. So, and then our overall patient satisfaction on our new portal was 4.6 out of 5 the first year. So we thought that was pretty good. Solutions implemented. So prior authorizations obviously is a big initiative for anyone out there. And as you saw from Clarissa, there is some new legislation coming out within the states, which I'm hoping that Utah is going to adopt pretty soon. We have some lobbyists working on that on our behalf, and some of our local and state organizations. So, but in the meantime, we still have to deal with it. So I think that right now, largely things are managed manually. I mean, we have those benefit managers that we can send a lot of things through depending on your payer, which is great. But I mean, we still have payers here that are doing things manually. And right now, though, we just have to track everything and make sure that, we have shared drives where all of our financial teams are able to access to say, well, what are the quirks? What are the quirks? What's the fastest way to get this dealt with? And we just maintain that as a team. And right now, just managing it manually. One of my initiatives is find some technology. Let's find some, machine learning, some AI that's going to help us with this. We've demoed a few, and I'm not going to lie, I haven't seen anything that really blows my socks off to this point. We've demoed a couple in an actual live environment, and it's just, it's a difficult thing for them to do because they use machine learning on the back end to log into some of these benefit managers for you. And some of the benefit managers saw different IP addresses. They saw something that flagged it that just made it more difficult. And in our practice, we're actually a pretty high functioning practice to where my financial team has it down so well that a system like that actually slowed us down, believe it or not. So quarterly policy reviews is a big thing for us, as I mentioned before. You have to stay on top of policy. Things are going to change. The insurance companies are not our friends. They're not looking to pay these claims. They would rather not pay these claims. Their CEOs and their executives are looking to pad the bottom line, just like in any business. They don't want to have to pay if they don't have to, so they're going to look for ways to reject. And unfortunately, we have to play that game in order to get paid. I always tell my team that there's two games that has to be played. One, we have to jump through the hoops, do what we have to do to get a claim paid, and then there's policy on the other hand. That's where we try to affect policy on the back end. But until we can actually make changes to policy, we have to play the game. And these quarterly reviews really help. And then again, we mentioned we're exploring all automation options. We have to find that median between technology and human beings. And I think we've done really well to that point. Our front end automation, like I mentioned, has reduced our initial out the door claim rejection. And our back end right now, as I'm exploring our back end denial management, is just to bring in some more machine learning to say, okay, how can we predictively remove these denials that we tend to see historically based on our historical data? And so I think that technology needs to be utilized. We can't remove that human component, but we need to utilize it. We need to work smarter, not harder. So more opportunities, I mentioned before. We are looking to reduce our administrative burden with authorizations through any kind of automation that we can find. I'm on a constant lookout for this. As I mentioned before, we're a fairly high functioning practice, and so we do really well, and I haven't been able to find anything to this point that will make that easier for us, but I'm always on the lookout. And again, the further automation, we have to work smarter, not harder. And this is going to come down to your system. Maximize the potential of your EMR, of your PM system. As my days back in the consulting days, I couldn't tell you how many times we ran into practices that, whether it be the EMR or their PM system, that they were just barely scratching the surface. And there was so much more to it that they didn't know about, but they never asked the question. Always ask the question. Always ask, can it do something that I don't have to do? Make the system work for you. IVR capabilities, that's a big thing for us. We have a real basic IVR that just is allowing patients to get in to take money, but there's a lot more that they can do. They can do scripted outbound patient engagement, where it's just an IVR that reaches out to a patient for a patient balance and says, would you like to talk to this person? Would you like to make a payment? And it just does that outbound call that you don't have to do, and it'll run through a list of thousands of contacts. Again, use that technology. Payer advocacy. Yeah, this is something that we just always remember. Maintain a good relationship. I mean, bad relationships don't do anything for you. You know, you'll catch more bees with honey. So, and then, you know, interoperability is a big thing. You know, allow your referring physicians and your referral base to access your system for results. I mean, be able to communicate with them easier, and allow physicians, you know, your outside physicians, to access anything they need to. We've allowed a lot of our high referral based physicians to, if they need to look into any, say, imaging results, lab results, things like that, or want, you know, collaborative efforts from our physicians, we allow access to that based on a case by case basis, of course. Still got to maintain HIPAA and be careful, but, you know, always keep those options of interoperability open. I mean, that just makes everything better for all of us. We get results, things happen quicker.
Well, thank you, Patrick, for sharing your experiences and such valuable insights on overcoming the very relatable challenges we're facing in today's healthcare industry. So, in speaking to reimbursement leaders within the health industry, all have noted that having incorrect patient demographics and insurance information and not knowing current payer policies or requirements had a downhill effect on the overall revenue cycle management process. Having accurate billing information upfront has an impact on your success for reimbursement, regardless of who you're billing for your services. Therefore, shifting everyone's mindset to looking at the overall end-to-end process is important for success. Patrick noted the importance of automation, and I want to really emphasize that as we continue to discuss adding value to your practice. All healthcare providers face daily challenges to maximize collections from payers. As mentioned previously, recent fee schedule changes have caused significant reductions in reimbursement, and changes in payer policies create added pressure on cash collections and profitability. Organizations need technology solutions that maximize automation. Incorporating new and useful automation capabilities into the revenue cycle management process will help maximize revenue, reimbursement, and workflow efficiencies, resulting in improved clean claim rates, improved cash collections, and profitability. Even in today's day and age, with advancements in technology, many providers rely on internal office staff to manage billing functions. If I recall correctly, Patrick actually mentioned earlier that he has 23 patient financial advocates at Utah Cancer Specialists. For most practices, the front-end billing functions include benefits investigations, prior authorization requests, and as Patrick mentioned, patient advocates who actually manage the patient relationships and help educate patients on navigating their healthcare and healthcare costs. Much of these tasks are administrative burdens since the processes are very manual in nature. Many practice staff are contacting payers by phone, also going on payer portals to verify eligibility and benefits. They're doing the same for prior authorization requests, as many payers require this process for certain medications, procedures, and services. So it's important to have billing technology with a direct connection to payers to perform electronic eligibility verification. Really having real-time 270 and 271 eligibility and benefit inquiry transactions can provide detailed benefit information, including coverage, co-payment, year-to-date deductible amounts, and coordination of benefits. This will result in fewer rejected claims, expedited reimbursement, increased efficiency and productivity, and reduced billing and collection costs. And I think Patrick can attest to this. Many community oncology administrators agree that they were more successful collecting patient out-of-pocket responsibilities upfront during the patient encounter rather than after the claims adjudication process, as it can take a patient statement, can often take about 90 days to be sent from the actual patient encounter. So having real-time eligibility transaction data is pertinent to determining the accurate co-payment and deductible amounts to collect payments from patients at the time of the actual encounter. Real-time eligibility verification can also help determine the correct insurance to request prior authorization. And I know Patrick actually touched a little bit on the prior authorization. Before turning the floor over to David Bird to discuss prior authorization in detail, I actually wanted to share a few ways to automate the front-end billing process that many revenue cycle management leaders have implemented as best practice solutions. So as mentioned, automation helps ensure faster, clean claim submissions and reduces labor costs. For example, Payor edit automation is a claims optimization tool based on payer requirements that identifies billing errors and allows providers the opportunity to review and resolve problematic claims before the actual claim is submitted to the payer. This results in less rework, quicker claims adjudication, and faster payments. Another example of automated workflow efficiency is integrating your practice management system or hospital information system to automatically generate 276 claim status inquiry transactions, as well as 277 claim status response transactions. This allows systems to automatically generate a claim status inquiry and or enable automatic posting of the status of the actual claim information into a patient account. The benefits of having these electronic transactions are real-time claims information, increased efficiencies and productivity, decreased duplicate claim submissions, and also improved cash flow. You really don't want your staff touching every single claim to ensure claims accuracy. Relying on human intervention causes unnecessary burden on your staff with an increased risk for clerical errors and compliance issues. You want to maximize operational efficiencies through the automation of revenue cycle management workflows. An exceptions-based billing platform can highlight billing errors or claims in which pertinent billing information is either missing or invalid and the information isn't there. Therefore, your staff is reviewing only a subset of claims that really need attention rather than touching every single claim. Another solution, and I think Patrick actually touched on this as well, is providers utilizing a client portal. A client portal is a secure web-based portal that improves engagement with referring providers to provide them the ability to give missing billing information or correct billing errors and upload patient billing documents. This type of portal improves billing workflows by allowing the editing of claims prior to the submission of the process. Billing errors that could stop a claim from being reimbursed can be identified on the front end and corrected using claim validation tools. Corrections made by the practice staff are made directly within the portal, and corrected claims follow an automated workflow, further expediting the claim submission process without the need for additional staff intervention. Referring providers can also upload patient face sheets or copies of insurance cards, medical records, or other requested documentation for claims processing and appeals processing. We actually did a recent case study showing a healthcare provider using a client portal to obtain corrected and missing billing information. And that actually reduced their turnaround time for obtaining this information from 90 days down to 20 days. So this is a true testament of how having a client portal could expedite claim submission and maximize cash collections. Another case study that was performed looked at the process of incoming phone calls of patients wanting to pay their medical bills. It was actually determined that it took an average of 2 to 3 minutes to answer those calls, which equated to approximately $1 in labor costs per call. If the patient wanted to make a payment over the phone, the time of the call extended and the labor costs increased exponentially. It was also noted that calls were not evenly distributed across the business day. Therefore, there was an influx of calls coming in during peak hours of the day, which actually led to challenges in managing call volumes and led to an increase of the average speed to answer and wait times, resulting in a negative patient experience. As a solution to this, a patient portal was implemented, which enables patients to securely access their account data anytime, anywhere, and update their demographic and insurance information, set up payment plans, view diagnostic records, and make real-time online payments. The portal actually created an additional patient touch point, which improved patient access, convenience, engagement, and overall satisfaction, as well as reducing labor costs, increasing staff productivity, reducing DSO and write-offs, which resulted in faster cash collections. I'm now going to go ahead and transition the presentation to David Bird, who will take a deeper dive into prior authorizations. David, you have the floor.
Thanks, Clarissa. I just want to say thanks to XIFIN and to the audience for attending today. I think Patrick has nailed the prior authorization with some of the challenges that he's seen in his own practice. I think we can all acknowledge that prior authorizations are a big challenge, not just within oncology, but across healthcare. And the payers just keep expanding the use of prior authorization for tests and procedures through their utilization management reviews. But as you can see from some of the statistics on this slide, the expansion of prior authorization only places a higher burden on the providers, their staffs, but more importantly, the patients themselves. And the challenges are pretty diverse, but basically stem from manual, tedious efforts that takes the patient access teams to obtain the auth. And again, as you can see from the statistics on the slide, the challenges span from impacting patient care to just obtaining the auth itself. As a matter of fact, the CAQH identified in 2020 in a study that they did that it can take 13 to 20 minutes to obtain an authorization, which I personally think is a bit conservative. For some of the procedures, we've seen it take up to 40 to 45 minutes. I think Patrick just confirmed that as well, to get the auth. So it's a big problem, not only for the providers, their staff, but it can be for the patients and the patient care, which everyone understands that impacts patient satisfaction scores. So the payers have set up this process that makes it difficult to obtain a prior authorization, even with the portals that they've established. And if you understand the hoops that you have to jump through to get approval, then you quickly understand that software can't handle the job by itself. It's just simply due to the constant changes payers make to the guidelines, the update they make to their portals, whether that's through just like an actual format change to the portal itself, or as Patrick again mentioned, if it's a clinical pathway question or just the overall guidelines. There's all these hoops to jump through. So taking machine learning algorithms to monitor historical and current payer behavior, and then applying technologies like artificial intelligence and RPA, which means robotic process automation, greatly helps automate certain aspects of the process. But again, what if a payer makes a change to the portal or changes the clinical pathway questions? No matter how good the technology is, or your AI is, or machine learning is, it only knows what it knows. And this is where combining human intelligence with technology has great advantages versus the software stopping in the process and kicking back to your patient access team to say, oops, sorry, I've gone as far as I can go. Now you need to take over. It's pointless. The point of a prior authorization product should be to eliminate your staff from worrying about if the software is going to fail, only to do the software's job. So combining technology with well-trained prior authorization specialists under one solution eliminates the need for your staff to have to follow up and manage where the prior authorization is in the process for approval. The goal should be to automate as much of the process as possible, only using prior authorization specialists when necessary. So how does it work? So with an API interface such as to XIFIN, the provider doesn't need to jump to a separate system to monitor their authorizations. They can simply monitor their process within their system. So there's a 4-step process, and the first step in the process is determination. And what determination does is it leverages artificial intelligence and machine learning to identify if that patient with that payer, with that specific CPT code requires an auth or not. And if it does require an auth, then it automatically moves to the second step, which is initiation. And initiation is just more than submitting the prior authorization. As Patrick identified earlier, each payer has its own requirements by procedure or by test. And so understanding what that payer requires is very important when you go to submit an auth. Because if you submit it without the criteria or the data that that payer is requiring, or even that benefit manager, they're going to deny the auth. So the second step goes beyond just submitting the prior auth. It identifies, okay, this benefit manager requires this, or this payer requires this procedure for this payer requires clinical documentation. So we need to be sure that we have that clinical documentation, because if we submit it, it's going to get denied. So it's a very thorough process by payer, by procedure or test. The third step is verification. And what verification simply means is that the software is identifying that the payer or the benefit manager has received the request, all the information is there, and they are processing that prior authorization. And then the last step is follow-up. And follow-up is really like an alerting mechanism. It's identifying to that patient access specialist where that auth is in the process, whether it's still under review, whether the payer may have questions about the data that's been submitted, maybe the clinical documentation didn't have the history of that patient that the payer wants to see, or if the prior authorization has been approved. If it has been approved, then all that information would flow back through the IPA or through the API into the appropriate system. And then the claim could go out from there. The only thing that the software and the specialist won't do is a peer-to-peer review. We will identify that there's a peer-to-peer view, but for obvious reasons, that payer is going to want to speak to that referring or ordering physician on why that test or procedure is being requested. So it's a simple 1 through 4 step process, but it combines both technologies and a human specialist where the technology can't address a change in the portal, a change in a guideline, or a change in certain clinical pathway questions. The nice thing about that is because we do have a specialist involved in the process, that specialist has a looping mechanism back to the software engineers to let them know that the payers have made a change along that process, so that process can get updated and automated if possible. So by combining advanced technologies with prior authorization specialists, the providers experience a positive impact on both the front-end patient access workflows, patient satisfaction, and then obviously downstream uplift from collections. The challenges in obtaining a prior authorization has greater impact than I think most practice administrators sometimes realize, because they're just not down into the weeds like the patient access specialists are. So prior authorizations across all specialties are usually the number one reason for denials, as Clarissa had the slide before, and write-offs. If they're not the number one reason, they're always in the top 3. And again, that's against all specialties in healthcare. Then there's the struggle of obtaining a qualified patient access specialist. And this is becoming a bigger and bigger problem within the industry. But it's not just obtaining that patient access specialist, but also keeping that qualified prior authorization specialist. That's become a big challenge. And that impacts patient satisfaction as well, which we all know is the provider's main focus, is, again, Patrick identified earlier. So as you can see from some of the statistics on the slide, combining human intelligence and machine learning with artificial intelligence can result in faster turnaround times, obviously reduce cost, and allow for appropriate reimbursement. It doesn't need to be a tedious process, and the patient access teams really don't need to worry about obtaining that auth when you have a solution that combines machine learning, artificial intelligence, and human specialists. Leveraging advanced technologies with those specialists can remove most of the headaches around obtaining an approval for a prior auth in a timely manner. And more importantly, it lets the staff focus on getting that patient scheduled and seen.
So thank you, David. I know from firsthand experience how much of an arduous task trying to keep up with payer prior authorization requirements can be, as well as the different nuances and inconsistencies with each payer. So we definitely appreciate the information you provided today. Much of this webinar has focused on optimizing revenue cycle management to strengthen your practice value. I've talked a lot about the front-end automation capabilities, so I'd like to share a few other key components as far as automation solutions that can help reduce costs, increase productivity, and maximize reimbursement. With federal and state guidelines, as well as payer requirements consistently changing, you want to ensure compliant, consistent billing practices are followed. Having automated capabilities ensures this. Having the ability to load payer clinical guidelines and medical policies can ensure claims meet the payer-specific diagnosis guidelines for medical necessity. Also, having automated consolidation rules with compliance logic and prompts can ensure the appropriate number of units for service is billed based on the payer's medically unlikely edits, or bundled services are built with a correct procedure code or modified or appended as needed based on the payer's national correct coding initiative edits. David mentioned earlier, and many of you know, that additional clinical information and patient medical records are required for prior authorization. In the past few years, we've actually seen an increase in payers requesting additional information prior to the claims adjudication. And also for some payers, they're asking providers to even provide supporting documentation with the electronic claim itself. And as part of the denial management, appeals require supporting documentation, usually to justify and support medical necessity. In these situations, direct connectivity and automation are key to achieving impactful results in managing an efficient claims process. Having a document storage and management system to securely upload documents can actually streamline workflows and improve efficiencies. Documentation can easily be uploaded and automatically attached to claims based on payer-specific requirements, as well as an automated appeals process based on claims adjustment reason codes. This improves the efficiency of claims attachment and appeals by up to, believe it or not, 300%, and dramatically reduces the cost of the appeals process. Patrick mentioned this earlier. Another thing to consider in maximizing workflow automation is leveraging an integrated IVR, or interactive voice response system, for incoming and outgoing calls and text messages to improve the user experience and increase patient payments in a cost-effective manner. Outbound IVR can be used with an aged receivables file to call patients when and where they're most likely to be reached. Patients can use the IVR to make credit card payments, transmit information to help them resolve account balances, and can be connected to a live person if needed. The IVR, along with the patient portal I mentioned earlier in the presentation, can greatly reduce costs and dramatically reduce your incoming calls by 20%, improving your current staff's productivity in other areas. Since everything we've discussed thus far ties into the financial reporting, I wanted to end my segment with the essential components of effective business intelligence. It's important to achieve full visibility into financial and operational performance and track key performance indicators and benchmarks. The Sarbanes-Oxley Act and the latest revenue recognition rules and the Financial Accounting Standards Board have strict revenue recognition guidelines. Diagnostic providers need to accurately determine contractual allowances, price concession percentages, and bad debt percentages, which can be managed with the right data analytics, providing auditable reporting and financial integrity. Improved analytics through business intelligence tools can target critical areas. You can actually identify the most common front-end billing issues and clients that may be triggering them, as well as finding trends with payer adjudications, denials, and reimbursement. Productivity analysis tools can also help you understand individual and team performance in executing specific billing tasks. Using advanced analytics, you can transform your insights from the data you capture into actionable items that can reduce the overall expenditure and maximize reimbursement. So just to summarize it all, community oncology practices face daily challenges to maximize payer reimbursement. Many factors we can't control add increasing pressures to revenue growth and profitability. Maximizing automation is a critical means for providers to gain a competitive edge. For revenue cycle management, process automation translates to maximized reimbursement and improved operational efficiencies. So this concludes our presentation of how to maximize oncology practice value. The first question asks, how much administrative time is spent on prior authorization? Patrick, would you mind answering this one?
Sure. That's a good question and a difficult one to quantify. Depending on practice volume, what they're treating, complex cases, it's a hard one to nail down. One of the things belonging to the NCCA is that they had estimated early last year that the average practice spends roughly $75,000 per provider per year on a prior authorization representative. I've done the estimates on our own side, and I know that on average, out of my 22 employees managing prior authorizations, in any given day, month, they spend on average probably 50% of their time dealing with prior authorizations. Earlier this year, we had to finally come to the conclusion that we needed to basically create a separate team for my chemo authorizations, and we called them our chemo team. We had to move these guys off site, and basically they do nothing but chemo authorizations. And then that took a lot of the burden off of our in-clinic advocates. And then they were just left to manage things like, genetic testing, imaging, and outside orders for MRIs and things like that. So that took a lot of the burden off of the in-clinic, but it didn't remove it. So, and that's just kind of where we're to the point now, just kind of figuring out how do I get it to where I can remove even more.
Yeah, and I can actually also share the American Medical Association, and I think David mentioned this, conducted a physician survey in 2020 specific to prior authorization. And on average, it stated that practices complete 40 prior authorizations per physician per week. Also, physicians and their staff spend an average of 2 business days or 16 hours each week on prior authorization processes. Definitely spending a lot of time there. I want to actually say that we appreciate your attendance and hope you were able to garner valuable information from our webinar. We would greatly appreciate it if you can provide your feedback by taking a brief survey that will appear momentarily. Please note that the recording and copy of the slide deck for this webinar will be available within a week. Thank you very much for your time and have a wonderful week.